my dear champions. Hope you are good and preparing well for your upcoming MRCOG Part 2 exam. Introducing myself, I'm Dr. Dinesh, one of the mentor of Team StudyMRCOG. So here today we are discussing about a very important topic of overview of cardiac disease as a part of KickStart series for your MRCOG Part 2 journey. So let's start this session with a beautiful quote. Strive not to be a success, but rather to be of value. And this value you're gonna gain with your knowledge, with your concepts. And that is the ultimate mantra to clear your MRCOG Part 2 in one go. So let's talk about the cardiovascular disease, cardiovascular condition during the course of pregnancy and what are the changes that do happens in the pregnancy. We understand that pregnancy poses the extra burden on the heart and heart has to cope up with it. So these things make certain things which is physiological and if it goes into the abnormal way, it turn up into a pathological and it could be a detrimental and life-threatening for the patient. So, in an order to make a dream of safe motherhood into the reality, we need to understand this topic up to the depth. So, cardiovascular disease complicates around 0.2 to 4% of all pregnancies in modern Western industrialized world. The majority of maternal deaths in United Kingdom are now from the acquired heart disease and the last Center for Maternal and Child Inquiries report noted that 11 maternal deaths resulted from myocardial infarction mostly related to the ischemic heart disease. In pregnancy, the relative risk is approximately 3 to 4 times higher than the estimated age-specific rates of myocardial infarction per 1 lakh women in a year of the reproductive age group category. The profound physiological changes in pregnancy and the postpartum period can put a strain on heart and that makes it is more difficult for heart to tackle with it if it doesn't go the way it's supposed to be. So in an order to understand the physiological change, let's understand with the cardiovascular changes and the hematological changes. Talking about the cardiovascular changes at the first. As early as 6 weeks of gestation, an increase in the plasma volume and reduction in the peripheral vascular resistance occurs because of the activation of renin-angiotensin system and mild reduction of the plasma arterial natriuretic peptide levels. The increase in blood volume continues until it plateaus at the level of 140 to 150% at around 32 weeks of gestation compared with non-pregnant state. Cardiac output increases steadily until 25 weeks of gestation, initially secondary to the increase in the stroke volume and latter because of increase in the maternal heart rate. During the labor and delivery, the further hemodynamic changes do occur. The heart rate, the blood pressure increases significantly as a result of pain, anxiety, and uterine contractions. The increase in the heart rate is similar to that observed during the moderate to heavy physical exercises. As a result, the cardiac output increases by 50% with each contraction. About 300 to 400 ml of blood is transferred from uterus into the circulation with each contraction. In the active phase of second stage of labor, the Valsalva maneuver results in the larger variation in the central venous pressure. The completion of the third stage of labor results in approximately 500 ml of uterine blood being returned to the maternal circulation, with associated increase in the ventricular preload, cardiac output, and central venous pressure. Approximately 48 hours after the delivery, diuresis and natriuresis starts with return of cardiac output, blood volume, and peripheral resistance to the pre-pregnancy state occurring over a course of 4 to 12 weeks. Talking about the hematological changes. Increased level of procoagulants and the reduced level of natural anticoagulants during the pregnancy induce a hypercoagulable state. While these changes aim to reduce the intrapartum blood loss and they increase the risk of thromboembolism. Level of fibrinogen, factor 7, factor 8, 10 and Wolff-Wilpens factor increases in pregnancy and contributes to the procoagulant state. In addition, during the pregnancy, the natural anticoagulant decrease as a result of lower level of functional protein S secondary to the increased level of its binding protein, the complement component C4b, and the increased level of plasminogen activator inhibitor type 1. The changes in the coagulation system do not return to the pre-pregnancy level until more than 8 weeks of postpartum. Compared with the rest during the pregnancy, and the risk of thrombosis is even higher after the delivery. Let's understand what are the NYHA classification, that is New York Heart Association classification system for the symptoms of cardiovascular disease. So, as per the NYHA, the classes are 1, 2, 3, and 4. So, in category 1, the symptoms, there could be no symptoms and no limitation in ordinary physical activities, example, the shortness of breath while walking, climbing the stairs, and etc. NYHA class 2, mild symptoms. It means that the mild shortness of breath and or angina, that is chest pain, and slight limitations during the ordinary activity. NYHA grade 3, the marked limitation in activity due to symptoms even during the less than ordinary activities. For example, walking a short distance near about 20 to 100 meters comfortably only at rest these patients. Severe limitation. This experiences the symptoms even while at rest, and mostly the bed-bound patients comes into the category of NYHA class 4. There are certain general principles in an order to tackle the cardiac condition during the pregnancy. In pregnant women with a heart disease, it is important to remember that the outcome and the safety of pregnancy are related to the presence and the severity of pulmonary hypertension and the presence of cyanosis, the hemodynamic significance of the lesions, and the functional class. The functional class is determined by the level of activity that leads to the dyspnea, that is, the breathlessness or shortness of breath. In addition, women with previous cardiac events, including the transient ischemic attack, arrhythmia, pulmonary edema, or heart failure, and those with a left sided lesion, example aortic or mitral stenosis, or myocardial dysfunction, are at risk in pregnancy. Women with congenital heart disease are at increased risk of having a baby with congenital heart disease and should therefore be offered a detailed fetal scanning for the cardiac anomalies by means of fetal 2D echo at 22 to 24 weeks of gestation. During pregnancy, women with heart disease requires multidisciplinary care with regular antenatal visits and judicious monitoring to avoid or to treat exponentially any anemia, infection, or hypertension. There should be early involvement of obstetric anesthetist and carefully it has to be documented the plan of delivery. There are a couple of things that you should be well aware about in terms of ECG. So, ECG changes during the course of pregnancy, how exactly it goes ahead. So, during the course of pregnancy, the diagnosis of acute myocardial infarction, how you'll come to know there will be ST elevation, ST depression, symmetrical T wave inversion, and there could be newly developed Q waves. There are certain normal variations in pregnancy near about 15 to 20 degrees left axis shift that could be noted. The ST segment depression is one of the normal variation. T wave inversion in inferior and lateral leads, small Q waves and inverted T wave in lead 3, Q wave in lead AV4, AVF. The inverted T wave in V1 and V2 and occasionally in V3. So these are the normal variation that need to be understood in order to avoid by mistake diagnosis of certain cardiac abnormalities. Talking about acute myocardial infarctions in pregnancy. The medical management of acute myocardial infarction in pregnancy, so there are the certain drugs can be safely used. For example, low dose of aspirin, nifedipine, labetalol, heparin. In heparin, it could be a low molecular weight or unfractioned heparin. There are the limited use and there are no other alternatives to the clopidogrel. There are certain drugs which are contraindicated, for example, statins, angiotensin converting enzyme inhibitor, and angiotensin receptor blockers. Let's come to the question. A 26-year-old woman is seen in the combined obstetric cardiology booking clinic at 14 weeks of gestation. She has history of teratology of palate that was repaired in childhood. What is the main cardiac issue that she potentially faces during the course of pregnancy? Left ventricular dysfunction, paradoxal embolism, profound cyanosis, pulmonary hypertension, or right ventricular dysfunction? A very well answered, it is a right ventricular dysfunction. A woman with repeated teratology of palate usually tolerate pregnancy well. The main issue is right ventricular dysfunction, which can deteriorate in view of pulmonary regurgitation resulting from the earlier surgery. As we know that the cardiac patients are more into the category to have the endocarditis or cardiac infections, and in an order to avoid that, there are certain prophylactic way. The UK recommendation from NICE guidelines are antibiotic prophylaxis against the infective endocarditis is not required for childbirth. According to the British Society of Antimicrobial Chemotherapy, and the American Heart Association have recommended cover only for a patient deemed to be at a high risk of developing infective endocarditis, such as women with previous history of infective endocarditis, and for those who have poorest outcome if they develop infective endocarditis, such as those with a cyanotic congenital heart disease. If antibiotic prophylaxis is used, it should be with amoxicillin 2 gram intravenous dose plus gentamicin 120 milligram intravenous at the onset of labor or ruptured membrane or prior to the cesarean section, followed by amoxicillin 500 milligram orally or given at 6 hourly interval. It can be given intramuscularly or intravenously depending upon the patient's condition. For women who are penicillin allergic, vancomycin 1 gram intravenous or tecloplanin 400 milligram intravenous may be used instead of amoxicillin. Talking about peripartum cardiomyopathy. So peripartum cardiomyopathy is something which is very important in order to understand a sudden cardiac death after the delivery. This pregnancy specific condition is defined as heart failure secondary to the left ventricular systolic dysfunction towards the end of pregnancy or in the month following the delivery, where no other cause of heart failure has been found. It is nothing but a diagnosis of exclusion. The left ventricle may not be dilated, but the ejection fraction is always reduced below 45%. The risk factors include the multiple pregnancy, hypertension, multiparity, increased age, and more commonly seen in African Caribbean risks. So, here the diagnosis should be suspected in puerperal women or those in late pregnancy with breathlessness and signs of heart failure. It is confirmed by the means of echocardiography showing left ventricular dysfunction and often dilatation of the all four chambers of the heart. Treatment is as for other cause of heart failure with oxygen, diuretics, vasodilator, AC inhibitors if the postpartum or inotropes if required as a management modalities. The prognosis and recurrence depends on the normalization of left ventricular size and the function within 6 months of delivery. A very important condition that we should be understanding in detail about pulmonary hypertension. What are the most common causes? The most common reason is idiopathic pulmonary arterial hypertension, or it could be because of the Eisenmenger syndrome. Eisenmenger, when the pulmonary hypertension develops secondary to a large left to right shunt, such as ventricular septal defect, and the shunt is reversed to become the right to left with a consequent cyanosis. It could be because of the secondary to the chronic pulmonary thromboembolic disease, secondary to the connective tissue disorder, particularly the scleroderma, sickle cell disease, and secondary to the cardiac lesions causing the raised pulmonary capillary wedge pressure, such as mitral stenosis. In this condition, the maternal mortality is 25 to 40%, although this is decreasing in the upcoming era of the modern medicines. How to manage with pulmonary hypertension? Either avoid a pregnancy, or in the event of unplanned pregnancy, we might need to think about the therapeutic termination. If such advice is declined and patient wanted to continue the pregnancy, then a multidisciplinary team approach has to be followed. As it is a hypertension, so vasodilation with the help of sildenafil or nebulized or intravenous prostacyclin may be considered. Endothelin antagonist, as we know that endothelin is something which is a vasopressor or vasoconstriction agent. So endothelin antagonist, that is the bosentan, are usually avoided as they are the teratogenic in rats, although it is not known whether they have the similar risk in humans. Coming to a question, a 25-year-old woman is seen in the antenatal clinic at 7 weeks of gestation. She is seen regularly in the congenital heart disease clinic because of the Eisenmenger syndrome secondary to the ventricular septal defect. What would be the most appropriate advice in terms of her further management? whether there should be a bed rest and home oxygen therapy, or either it should be better to commence on oral labetal or oral sildenafil, or commence the thromboprophylaxis with low molecular weight heparin, or we should go for termination of pregnancy. Yes, it is a termination of pregnancy. As a part of review of literature between 1997 to 2007, showed a maternal death rate of near about 17% in idiopathic pulmonary arterial hypertension, 20% in congenital heart disease associated with pulmonary hypertension, and 33% in the other forms. Therefore, such a woman should be actively advised against the pregnancy, and adequate contraception should be recommended, such as subdermal progesterone only implants. If they do become pregnant, the termination should be offered. Termination itself is associated with the maternal mortality is up to 7%, but this is less than that associated with such a pregnancy that allowed to progress. Coming to the question, 37-year-old primary gravida of African origin with a BMI of 38 kg per meter square attains the emergency department with shortness of breath, edema, and tachycardia. She has no proteinuria but admits with a family history of hypertrophic cardiomyopathy, and it becomes apparent that she is hypertensive with a blood pressure of 153 by 100 millimeters of mercury and needs treatment prior to the investigation. Which of the following antihypertensive is most appropriate? The answer is C, that is labetalol. Nifedipine should be avoided owing to the vasodilation. Methyl dopa will take a while to work, and amlodipine is not used as a first line of antihypertensive. Hydrolazine promotes the hyperdynamic circulation with adverse cardiac function, and the safest choice, the first drug of choice, comes in a favor of labetalol. Coming to one more question, you are called to emergency cardiac arrest on a labor ward, and first year trainee of 2 doctor was inserting a new cannula in 29-year-old 70 kg woman 2 hours postnatally, and she assessed the cannula with 10 ml of 1% lidocaine instead of 0.9% of sodium chloride. A CPR has been recommended by the time of your arrival. What should be injected immediately into the woman while CPR is taking place? So, in this category, understand the intralipid of 20% intravenously, that is 1.5 ml per kg, or a 1 minute is needed immediately in cases of collapse or secondary to the local anesthesis toxicity. And this should be followed by infusion of 0.25 milligram per kg per minute. Calcium gluconate is used in magnesium sulfate toxicity or in hyperkalemia. Adrenaline 1 milligram intravenously is used during the cardiopulmonary resuscitation as a part of advanced life support, although the optimum dose of adrenaline to use in cardiac arrest is unknown, but 50 microgram intravenously is significantly lower than the recommended dose. So this is how to tackle with the toxicity of the anesthetic agents given intravenously. Coming to the another question, a 29-year-old primary gravida in her first pregnancy and attends the antenatal clinics at 32 weeks of gestation. She is fit and well with no comorbidities. She had vasovagal fainting episodes and underwent a ECG, which was normal. Which of the following features would have prompted a suspicion of underlying abnormalities? Either it is a atrial ectopic bits or right shift to the QR axis, ST segment depression and T wave inversion in the inferior and lateral leads, or small Q waves with inverted T waves in lead 3 or ventricular ectopics. The answer is B, that is the right shift in the QR axis. It is normal to see the left axis shift in QRS axis, but right shift may indicates the right ventricular hypertrophy as the right ventricle is enlarged and generates more electrical activity. A 34-year-old Pakistani woman in third pregnancy attains the antenatal clinics at 36 weeks for labor plan. She tells you that she is on beta blocker and she suffered from rheumatic heart disease as a child. Which of the following therapy we should be avoiding to the second stage of labor? Either it is intravenous benzyl penicillin or intravenous ergometrine, intravenous oxytocin, intramuscular oxytocin, or intravenous sodium chloride with potassium chloride. So answer here is going in favor of B, that is intravenous ergometrin. Rheumatic endocarditis causes the mitral stenosis in 75% of the patients, and ergometrin causes the rapid autotransfusion and can precipitate the pulmonary edema, and so the ergometrin should be avoided. So let's talk about mitral stenosis. It is the one of the most common rheumatic heart disease. The commonest complication is pulmonary edema, which is secondary to the increased left arterial pressure, and it can be precipitated by increased heart rate and increased volume, such as which occurs during the third stage of labor. The risk is increased with the severe mitral stenosis, moderate or severe symptom prior to pregnancy, and those diagnosed late in the pregnancy. Severe mitral stenosis should be advised to delay a pregnancy until or after balloon open or closed mitral valvotomy or mitral valve replacement. The beta blocker decreases the heart rate and the risk of pulmonary edema, but if fails or those with a severe mitral stenosis, balloon mitral valvotomy may be safely and successfully used in pregnancy. Avoid supine and lithotomy position where there is an increase in the cardiac volume of the blood. So it is much better to avoid this position, that is supine and lithotomy position, as much as possible during the labor and delivery. Fluid overload must be avoided, and that's the reason fluid charting is very important in a patient of cardiac conditions. Pulmonary edema should be treated in the usual way, for example, by giving the oxygen and diuretics so that there will be decrease in the load on the heart. Talking about mechanical heart wall. So it required the prolonged anticoagulations. Pregnancy itself increases the risk of thrombosis. Warfarin is associated with the warfarin embryopathy and increases the risk of miscarriages, stillbirth, and the fetal intracerebral hemorrhages. Heparin is associated with the increased risk of wall thrombosis and embolic events. So, in the part of management, the safest option for some mother is to continue warfarin throughout the pregnancy because with the heparin, a event of thromboembolism could be there. The other management strategies include replacing warfarin with a high dose of low molecular weight heparin either from 6 to 12 weeks of gestation to avoid the warfarin induced embryopathy or throughout the course of pregnancy. Whichever management option has been chosen, the warfarin should be discontinued and substituted with the low molecular weight heparin 14 days prior to delivery to allow the clearance of warfarin from the fetal circulation. For delivery itself, the heparin therapy is interrupted but restarted in the postpartum. Warfarin is recommended 5 to 7 days of the postpartum. In the event of bleeding or need for urgent delivery in fully anticoagulated patient, warfarin may be reversed with prothrombinase complex and vitamin K and heparin with the help of protamine sulfate. A 46-year-old lady who conceived with a womb donation, presence at 34 weeks of gestation with a sudden onset of central chest pain and breathlessness. She smokes about 15 cigarettes per day. On examination, her pulse is 98 beats per minute and her blood pressure is 100 by 70 millimeters of mercury. The symphysiofetal height is appropriate for a gestation and the fetal heart is heard normally. The chest x-ray is reported to be a normal and ECG shows a sinus rhythm with T-wave inversion noted in lead 3 AVL and AVF. So what could be the situation? Is it a gastroesophageal reflux, pneumonia, pneumothorax, ischemic heart disease, or aortic stenosis? And the answer is in favor of ischemic heart disease. The history of home donation itself suggests the history of premature ovarian failure, and this combination with smoking increases the risk of coronary heart disease, and ECG changes are indicator of inferior wall ischemia. So let's talk about ischemic heart disease in the pregnancy. This is the most common. As maternal age and the obesity increases, the risk of myocardial infarction is increased in women over a 35-year-old, a multigravida, or those who smokes, or women with diabetes, obesity, hypertension, and hypercholesteremia. Acute coronary syndrome may be diagnosed as in non-pregnant patient with raised troponin level which is not altered by pregnancy and ECG changes. Infarction most commonly occur in the postpartum period. So maternal death rate is near about 10%. As a part of management of ischemic heart disease, the management of acute myocardial infarction is as far as same as like a non-pregnant female. Coronary angiography should not be withheld in pregnant patient. Percutaneous coronary intervention may provide a better alternative to thrombolysis in pregnancy as it is associated with less bleeding risk and also allows the management of spontaneous dissection with coronary artery stents. However, the stent implantation may be associated with the increased risk of coronary dissection in vulnerable vessels. For secondary prevention in women with known ischemic heart disease, both aspirin and beta blockers are very safe in pregnancy. Statin should be discontinued prior to and during the course of pregnancy as it is not recommended to use. Coming to the question, a 26-year-old woman presented at 27 weeks of gestation in her second pregnancy with severe chest pain that radiates to her back. Her height is 170 cm, quite tall. She has been noted having a hypermobile joint connective tissue disorder. On examination, she looks unwell with a pulse rate of 136, tachycardia, the blood pressure that is 76 to 46 millimeters of mercury, hypertension. So the chest X-ray is reported to be normal and ECG shows the sinus rhythm with a heart rate of 128 beats per minute. So, what could be the diagnosis of this condition? As I said, the buzzwords, it goes in the favor of aortic dissection. There is a high index of suspicion for this life threatening condition, and it looks like the features of Marfan. So, aortic dissection. The most cases occurs in late pregnancy or at or near term or in early puerperium. What are the causes? It could be a bicuspid wall, aortic coarctation, Turner syndrome, Endler-Danlos syndrome of vascular type 4, Marfan syndrome, Marfan, which is an autosomal dominant condition, a progressive aortic root dilation, and an aortic root dimension which is more than 4 cm are associated with the increased risk. Conversely, in patient with minimal cardiac involvement or aortic root dilation less than 4 cm, the pregnancy outcome is good. There is a five-fold increase in aortic complications in women with Marfan syndrome. So, how to manage with these cases? So, as a part of clinical feature, there will be severe chest pain or interscapular pain, systolic hypertension, different blood pressure in each arm or early diastolic murmur. The urgent imaging with the CT, MRI or echocardiography is essential as it is an emergency. Effective control of blood pressure, aortic root more than 4.5 centimeters should be avoided to delay the pregnancy, and there should be a serial echocardiogram and the beta blockers to be started. If it is pregnant and if the root dimension is less than 4.5 centimeter, definitely vaginal delivery is recommended, or you can try elective cesarean section with epidural if the root dilation is more than 4.5 centimeter. Coming to our question, 32-year-old Asian lady who has recently moved to the UK and present at a 20 weeks of gestation in her third pregnancy with left-sided chest pain. She describes becoming increasingly breathless over the past 4 weeks. She gives a recent history of easy fatigability and lassitude. On examination, her pulse rate is 88, BP is 96/70. Auscultation of the heart reveals the muffled heart sounds, and ECG shows the low voltage complex. So, what could be the diagnosis? Is it a myocarditis, aortic dissection, pleural effusion, anemia, or pericardial effusion? So, it is a pericardial effusion because of the tuberculosis can present in this manner, and these are the signs which are suggestive of pericardial infusion. Coming to one more question, 30-year-old school teacher presented at 30 weeks of gestation with right-sided chest pain, which is made worse on coughing. She also complains about the productive cough. On examination, her pulse is 110 beats per minute, her blood pressure is 100/76, her temperature is 38 degrees Celsius, and the heart sounds are normal. The breath sounds are diminished on right side, and chest shows the ground glass appearance. As we know in pathology, we are very well aware about this ground glass appearance, and yes, it is a pneumonia because here you could see the symptoms in a combination of fever, productive cough, chest x-ray with the ground glass appearance suggestive of pneumonia. There are certain special situations where we come across and we should have certain idea how to go ahead and deal with. If there is any need of syntocin in augmentation in labor, use a double strength syntocin but half rate to reduce the total volume of fluids which is given, and this decision need to be taken at the consultant level. There could be a situation where the syntonon as a prophylaxis against the postpartum hemorrhage. In that context, low dose infusion, that is 12 milliunit per minute, use either 5 international unit in 50 ml at 7 ml per hour, or 10 international unit in 500 ml at 36 ml per hour, and it has to be continued for a 4 hour or longer if there is any concern. If there is a preterm labor, prefer a tocilizumab as a first line management. Do not use the Ritotin or salbutamol. Pacemaker, if there, then definitely do not use any unipolar dithermy. Be aware of pacemaker in unusual places. For example, it could be into the abdominal wall or where you are performing a C-section. So always mention into the notes of the patient or clinical history where the pacemaker is located, and deactivate the implantable defibrillators. If there is a postpartum hemorrhage, that is one of the more likely conditions that do seen in the obstetric emergencies. Inform anesthetist and obstetric consultants on call about the patient's condition as they are into the cardiac category. For the uteronic misoprostol, 600 microgram rectally is preferred, but monitor the hyperpyrexia. Avoid the hemabet or high dose of syntocinon. Consider the use of compression sutures. Consider the use of intradental balloon tamponade. Antibiotic cover is recommended over here. Strict input-output charting as it is a cardiac condition, very importantly to be noted over here. And consider the central access or arterial monitoring for this patient as they are into the category of cardiac disease. And here we come to the end of the session about the overview of cardiac disease during the course of pregnancy. Yes, the exam do come up with some questions, more likely exam essentials one we have discussed over here. If you have any queries and concerns, please drop your messages into the chat box. We'll be very happy to help you out with this journey of part 2 preparation. So now we are coming to the closing of this session. Thank you and wishing you all the best with lots of love. I'm Dr. Dinesh, one of the mentor of Team Study Medics.